because these are the most important topics in the retina, and these questions have been frequently asked in your exams, or it could come in your exams this year. Okay, so before starting today's lecture, I'd like to tell you about a brief description of Auricle. So here at Auricle, we have recorded classes, we have live classes, practical sessions, exam module, hard copy book set. So these recorded classes, it offers you the freedom to choose from multiple educators for each subject. And these recorded classes covers your MBBS Prof exams and also your entrance exams. Okay, so these recorded classes provides you flexible learning with expert instruction, and it also helps you to conveniently revise your syllabus at the last moment of time. Okay, other than that, we have live classes like this, where you will have in-depth coverage of the topics. And these live classes are taken up by the experienced educators. And you can also participate in live doubt clearance, MCQ polls, and Viva questions. We also have rapid express exam modules. These exam modules covers your entire syllabus in under 20 hours and provides you with the answer writing skills as well. And this express exam module is specifically made to cater your revision needs in the last moment of time just before your exams. Okay, we also have one-to-one doubts clearing session. This doubt clearing session is made such that it provides a very student-centric approach for us, and also it gives personalized attention to every student for their doubts, and it helps us to create a safe learning environment for the students. Okay, we have the hard copy note set. So these notes are made in a very crisp and concise manner so that you don't need to read every line of your textbooks. Okay, so these notes covers every important and topic, important in previous year topics that has been repeatedly asked. And these notes are made in a very colorful and attractive manner such that it will be easier for you to remember those things or to read those things. Okay, and these notes also contains diagrams in it, which you can draw in your exams. We also have the question banks. So the question banks contains questions which are very necessary to practice just before your exams. Okay, so it is just like a practice session, and it covers your MCQs for all your prof exams, for your NEET PG or your other entrance exam, and also for your FMG exams. Okay, so these MCQs are from beginner to expert level. It has all the kind of MCQs from easy to hard. Okay. Other than that, we have practical sessions also, because practicals are as much as important as that of your theories. And these Auricle's practical classes provides hands-on experience and in-depth understanding of your MBBS practicals. It also tells you how to answer your Viva questions. And after watching or doing these practical sessions, you will gain some confidence and skills which is needed in your practical exams. We have 4 kinds of subscription plan here at Auricle. So these subscription plans are a foundation plan or advanced learning plan or complete learning plan or the ultimate MBBS plan. So these 4 plans vary according to the duration of the validity. Okay, so we have for 3 months, 6 months, 12 months, and the 4 years. Okay, so if you want for only a year, then you can opt for the complete learning plan. And if you want for the whole of your MBBS journey, if you want us to be with you for your whole MBBS journey, then you can opt for this ultimate MBBS plan. Okay. So now starting on today's topic, that is disease of retina. Okay. So we are discussing the first thing that we are going to discuss about is the proliferative diabetic retinopathy, or you can say the diabetic retinopathy. Okay. So we are going to discuss about the diabetic retinopathy in detail today. So we have discussed many topics earlier in our live sessions. And in many topics, we have discussed diabetic retinopathy as a complication of many such diseases. Okay. So diabetic retinopathy is a complication of number of diseases, of various number of diseases. So we will discuss today about this disease in detail. So first of all, we'll discuss about the definition of diabetic retinopathy. So the proliferative diabetic retinopathy, in short, it is known as PDR. In short, it is known as PDR. So it is a advanced stage of diabetic retinopathy. Okay, it is an advanced stage of diabetic retinopathy characterized by the formation of abnormal new blood vessels. Okay, abnormal new blood vessels are formed, which is also known as neovascularization on the retina and the optic disc. That means you can visualize these new blood vessels forming on the retina and the optic disc via fundus examination. Okay, so retina and optic disc are visible when you examine your fundus. Okay, and that is known as fundoscopy. So when you do your fundoscopy, you can identify the stage of your diabetic retinopathy, whether it has been proliferated or not. Okay, so the proliferated diabetic retinopathy is characterized by the abnormal new blood vessel, that is neovascularization on the retina and the optic disc due to the ischemia. And why these new blood vessels are forming? It is forming due to the ischemia caused by the prolonged hyperglycemia. Okay, so the diabetes is a hyperglycemic state. Okay, diabetes is a hyperglycemic state. The amount of glucose increases in your blood. So because it is a hyperglycemic state, it causes ischemia. Okay, hyperglycemia causes ischemia. That is reduced blood flow to the tissue or organ. Okay, so if there's ischemia in the optic disc or the retina, that is decreased blood supply. So the retina and the optic disc will need new blood vessels. Okay, and the new blood vessels that has been formed on the retina and optic disc is not normal. Okay, it is not normal, it is abnormal. So that is known as proliferative diabetic retinopathy. Retinopathy means there is a dysfunction of retina or there is a disease of retina, and it is associated with the diabetic condition. Therefore, it is known as diabetic retinopathy. And the term proliferative means it has been proliferated or it has been advanced. Okay, the disease has been advanced. So what is the pathogenesis of diabetic retinopathy? So first of all, there's a hyperglycemia stage due to diabetes, and due to this hyperglycemic stage, there is retinal capillary damage. Okay, retinal capillary damage due to the increased amount of glucose in the blood. Okay, the retinal capillary has been damaged, and this causes ischemia. So this ischemia increases the vascular endothelial growth factor, that is VEGF. Okay, this uh, ischemia causes increased amount of VEGF in the blood, and this VEGF in turn causes neovascularization. So this ischemia is responsible for formation of new blood vessels, which is abnormal. Okay, now these new blood vessels that has been formed are fragile. Okay, so these fragile vessels causes hemorrhage and fibrosis. So the hemorrhage and fibrosis of the fundus, okay, that includes retina and the optic disc, which in turn causes tractional retinal detachment. So the retina can be detached from the other two layers of your eyeball. So like this is our cornea, right? And this is our whole eyeball. So we have the outermost layer, that is sclera, right? The one I'm drawing with red. This is sclera. And the inner to the sclera, we have choroid layer. And the innermost layer is the retina. So the retina becomes detached from the other two layers, that is choroid and the sclera. So that is known as retinal detachment. And tractional retinal detachment means that a force has been generated, a force has been applied to the retina from the vitreous humor side, right? From the vitreous humor side, or you can say from the optic disc or the vitreous humor. So from the optic disc or the vitreous humor, there a force has been applied to pull the retina towards itself. So the retina becomes detached from the other two layers of the eyeball. So that is known as tractional retinal detachment. So retinal detachment can occur as a complication of diabetic retinopathy. So what is ETDRS classification of diabetic retinopathy? So the full form of ETDRS is the first classification of diabetic retinopathy is the mild non-proliferative diabetic retinopathy, that is NPDR. So in the first classification, we have only the presence of microaneurysms. So given on the diagram right hand side, you can see the microaneurysms over here. So these are the aneurysms. Okay, so these are the microaneurysms. That is the dilatation of the blood vessels. Okay, dilatation of blood vessels is known as the aneurysms. So the presence of microaneurysms only if the retinopathy has not been proliferated. So it is a mild non-proliferative diabetic retinopathy. And if there is moderate non-proliferative diabetic retinopathy, there will be dot and blot hemorrhages. Okay, dot and blot hemorrhages. For example, this. this is the dot in blood hemorrhages. The vessels will burst, and there can be blood spots visible on the fundus examination, and they can also be microaneurysms, and the hard exudates. Okay, so the hard exudates means the exudates are formed just like this. Okay, over here, these are the exudates released from the blood vessels, and there can be mild retinal edema and venous tortuosity. Okay, the venous tortuosity can be present, and there can be mild retinal edema. The retinal edema is due to the inflammation due to this hemorrhages that is causing. Okay, so if there is a severe NPDR, okay, we have discussed about the mild and the moderate NPDR, that is non-proliferative diabetic retinopathy. If there's severe NPDR, so there is a feature of 4-to-1 rule. Okay, so this is a very important rule. This is 4-to-1 rule. So 4-to-1 rule, that means there is hemorrhages or microaneurysms in the 4 quadrants of the optic disc. So 4 quadrants of optic disc, right? 4 quadrants of the optic disc. So hemorrhages or microaneurysms are present in the 4 quadrants. Venous beading. Okay, venous beading is present in the 2 quadrants. Beading means, for example, this is my vein. So there is a beading, means like the spots, okay, like beads. These are the venous beading. So venous beading is present in greater than 2 quadrants, and intraretinal microvascular abnormalities known as IRMA. In short, it is known as IRMA. Intraretinal microvascular abnormalities is present in 1 quadrant. So this 4-to-1 rule is according to the features that is present in number of the quadrants. So the hemorrhages or microaneurysms are present in the 4 quadrants, and the venous bleeding is present in 2 quadrants, and the IRMA or the intraretinal microvascular abnormalities is present in only 1 quadrant. So this is 4-to-1 rule, and it is present only in the severe category of NPDR. Now, what is PDR? So this was all about the non-proliferative one. Okay, so this was about non-proliferative diabetic retinopathy. Now we'll discuss the proliferative diabetic retinopathy. What are the features? So in proliferative diabetic retinopathy, there is abnormal new blood vessel formation, that is new vessel formation. So other than that, we have vitreous hemorrhage or the tractional retinal detachment. Okay, so vitreous hemorrhage can be present as a result of the complication of proliferative diabetic retinopathy, and tractional retinal detachment can also be present. Now, what are the clinical features of the proliferative diabetic retinopathy? So there can be gradual loss of vision, sudden vision loss due to vitreous hemorrhage or tractional detachment, because I told you that vitreous hemorrhage or tractional detachment can occur as a complication due to proliferative diabetic retinopathy, and they can also be flashes of and floaters due to retinal traction. So these are the symptoms. You can have a gradual or sudden loss of vision, and you can also have flashes and floaters in front of your eyes. So what are the fundoscopic findings? So in the fundoscopic finding, the most important fundoscopic finding is the neovascularization or the abnormal new blood vessels that is clearly visible on the fundus picture. Okay, and you can also have vitreous or preretinal hemorrhages. Preretinal hemorrhages means hemorrhages occurring in front of the retinal layer. So that is preretinal hemorrhages, or they can be vitreal hemorrhages as well. Other than that, we have fibrovascular proliferation or tractional retinal detachment, or hard exudates or cotton wool spots if NPDR coexist. Okay, so if NPDR coexist with the PDR, okay, so there can be non-proliferative diabetic retinopathy coexistent with proliferative diabetic retinopathy. So if both non-proliferative and proliferative coexist with each other, so then you can have cotton wool spots as your fundoscopic finding. So that is one important point that you need to remember. So the fundoscopic findings reveals neovascularization, vitreous hemorrhages, preretinal hemorrhages, fibrovascular proliferation, retinal detachment, that is tractional retinal detachment, or hard exudates and cotton wool spots if it coexists with non-proliferative diabetic retinopathy. So these are the 5 fundoscopic findings, which is very important, and the symptoms include the gradual and sudden loss of vision or the flashes and floaters. Now, how do you manage this condition, that is proliferative diabetic retinopathy? So the management includes medical management or laser therapy. So the medical management includes to optimize the blood sugar, because all these things is happening because of the hyperglycemic condition. And the hyperglycemic condition, if the hyperglycemic condition is controlled, then ultimately the disease will be cured. Also, if there is high blood pressure, then you have to control the high BP or the lipid levels. Okay, so you can optimize your blood sugar or BP or your lipid levels in your blood. Or if it is not controlling even by these methods, then you can opt for the laser therapy. In the laser therapy, the most common mode of management is the pan-retinal photocoagulation, which destroys your ischemic retina to reduce the VEGF production. So if you remember the pathogenesis, I told you that due to the hyperglycemic condition, uh, due to the diabetes, there's a hyperglycemic condition, and due to that hyperglycemic condition, there's ischemia, and due to the ischemia, there has been release of VEGF. Okay, that is vascular endothelial growth factor. And if you want to reduce the VEGF production, then automatically the new abnormal blood vessels which was forming will not form. Okay, so if you want to destroy the ischemic retina, then pan-retinal photocoagulation is the best technique to do that. Okay, so pan-retinal photocoagulation is the widely used technique if you want to permanently treat your proliferative retinopathy, and it acts by reducing your VEGF levels in blood. Okay, other than that, we have anti-VEGF therapy as well. So these include intravitreal injections of ranibizumab or bevacizumab. Okay, so these are the two monoclonal antibodies. Okay, these are the two monoclonal antibodies. So they target against the VEGF. Okay, so if you give these injections of ranibizumab or bevacizumab, intravitreal injections, then this acts against the VEGF, and this reduces the amount of VEGF, and ultimately the new abnormal blood vessels formation is reduced. Okay, the last mode of management is the surgery. The surgery includes the past vitrectomy of a non-clearing vitreous hemorrhage or tractional retinal detachment. So surgery is only preferred if you have vitreous hemorrhage or a retinal detachment as a complication of this proliferative diabetic retinopathy. And you can go for vitrectomy, that is removing of the whole of the vitreous humor. So there is no hemorrhage or there is no retinal detachment. Okay, so this was about the proliferative diabetic retinopathy. So we have discussed about the definition, about its symptoms, fundoscopic pictures, and about its management. So next topic is metagenous retinal detachment, in short known as RRD. So separation of the neurosensory retina from the retinal pigment epithelium due to the retinal break. So the neurosensory retina is detached from its retinal pigment epithelium due to the retinal break, allowing vitreous fluid to enter the subretinal space. So in the diagram, you can see the neurosensory retina over here. So the neurosensory retina is separated from the retinal pigment epithelium. Okay, so this is the neurosensory retina. This is the neurosensory retina, and this is the retinal pigment epithelium, which is known as RPE in short. So neurosensory retina is separated from the retinal pigment epithelium due to a retinal break, okay, allowing vitreous fluid to enter the subretinal space. So subretinal space is present between the neurosensory retina and the retinal pigment epithelium. So if there is a break between these two layers, then the vitreous fluid will enter in the subretinal space, and this causes retinal detachment, that is rhegmatogenous retinal detachment. What are the clinical features of rhegmatogenous retinal detachment? So there can be sudden onset of flashes or photopsia. We say it, photopsia. They can be floaters, or they can be peripheral central vision loss, that is curtain falling. Okay, peripheral or central vision loss can also occur as a symptom of rhegmatogenous retinal detachment. In the fundoscopic features, you have retinal break or tear. You can have detached retina, which appears elevated, mobile, and corrugated. And you can also have subretinal fluid accumulations. Okay, so retinal break or tear, which is clearly which will be clearly visible in the fundoscopy. There is detached retina, which is also clearly visible in the fundoscopic examination, and there can be also subretinal fluid accumulation. Okay, so these are the fundoscopic pictures. Okay, in the symptoms, we have photopsia, we have floaters, just like that of the proliferative diabetic retinopathy, and they can be peripheral or the central vision loss. Okay, they can be peripheral central vision loss, uh, which is also known as curtain falling. So it will appear as a curtain is falling in front of your eyes. Everything is becoming very blurred, or it is becoming invisible in front of you. Okay, so that is only that is only for a transient period of time. Next we have risk factors for the retinal detachment. So it includes ocular systemic risk factors. The ocular risk factors include myopia, especially high myopia, history of ocular trauma or surgery, that is cataract surgery, lattice degeneration, or retinal detachment. So myopia or ocular trauma or lattice degeneration or the retinal detachment in the fellow eye, that means in the other eye. Okay, so these are the risk factors for causing retinal detachment. And the systemic risk factors is aging or connective tissue disorders like Marfan syndrome. So Marfan syndrome is one of the most important of risk factor for causing retinal detachment. And the second most important is the myopia. Okay, so if you have myopia, then you are at high risk for developing retinal detachment. So how do you manage this condition of retinal detachment? So a prophylactic treatment, if you have one of the risk factors of retinal detachment, so you can get prophylactic treatment, which includes laser photocoagulation or cryotherapy for lattice degeneration or small retinal tears. Okay, so if there's small retinal tears, which is not significant enough to produce any symptom, so you can get laser photocoagulation or cryotherapy as a prophylactic treatment. Other than that, if you have the full-fledged symptom of retinal detachment, then you can go for surgical treatment, which includes pneumatic retinopexy, scleral buckling, or past planar vitrectomy. So vitrectomy is also the surgical treatment for the proliferative diabetic retinopathy as well as retinal detachment. Okay, scleral buckling, that means indenting the sclera to close the break. Okay, we indent the sclera to close this break between the retinal pigment epithelium and the neurosensory retina. Okay. Pneumatic retinoplexy includes injection of gas bubble into the vitreous. Okay. If we inject gas bubbles into the vitreous, which is known as pneumatic retinopexy, then this tractional retinal force, which is applying from the vitreous side, that will not happen. Central retinal artery occlusion, our next topic of discussion. So this is a sudden obstruction of blood flow in the central retinal artery, leading to the retinal ischemia. Okay, so the central retinal artery, which is the main artery supplying the retina. So there's obstruction of the blood flow in this artery, which leads to the retinal ischemia. Fundoscopic findings include pale retina because the arterial supply has been reduced. That's why the fundus appears very pale in color with a cherry red spot in the macula. So this is a cherry red spot in the macula. This is cherry red spot in the macula with the attenuated retinal vessels. Okay, so the attenuated blood vessels are seen because of the obstruction. So if there is if the obstruction is present over here, then attenuation can be seen distal to the obstruction, and the cherry red spot is seen specifically at the macula. Okay, and the retina will appear, the fundus will appear very pale because the arterial supply has been reduced. The complications of central retinal artery occlusion includes a neovascular glaucoma, okay, and or optic atrophy. Optic atrophy because the optic nerve also needs blood supply from the central retinal artery. Okay, optic nerve can't function if there is the insufficient blood supply from the retinal artery. So if there's obstruction to the central retinal artery, then the optic nerve will become dysfunctional, or there can be optic atrophy, and there can also be neovascular glaucoma. Okay. Similarly, we can also have central retinal vein occlusion because we have one central retinal artery, and one central retinal vein. So if there's central retinal vein occlusion, it will lead to the retinal congestion and hemorrhage because there is insufficient drainage of the blood from the retina. Okay, so the fundus picture will look like retinal congestion and retinal hemorrhage. So there is dilated and tortuous veins on the fundus examination with retinal hemorrhages in all quadrants. which is known as blood and thunder appearance. So you can see in the diagram on the right hand side, the nerve is swollen. The nerve, which is optic nerve, is swollen. Okay, the vein is swollen. This is the vein. The vein is swollen and bleeding in the retina in all four quadrants. Okay, bleeding in the retina in all the four quadrants. So this is the bleeding, and this is the nerve. Nerve is swollen, and this is the vein is swollen. So there is swelling of the vein or the optic nerve, and there is retinal hemorrhages. Okay, and what is the complications of this central retinal vein occlusion? There can be macular edema or neovascular glaucoma. So neovascular glaucoma is common to both CRAO and CRBO, and macular edema is particular complication to the central retinal vein occlusion. Now, what is hypertensive retinopathy? Just like diabetic retinopathy, we have hypertensive retinopathy, and these two also can coexist with each other. So the classification of hypertensive retinopathy is most important. So we'll only discuss about the classification part. So the grade 1 includes the mild generalized arteriolar narrowing. Okay, so there is mild generalized arteriolar narrowing. So there are number of arterioles present in the retina. So there is arteriolar narrowing because of the hypertension. And grade 2 includes the AV nicking and the localized narrowing. There's arteriovenous nicking. So the junction of the artery and the vein is nicked, and there is localized narrowing of the artery and the veins. Okay. In the grade 3, we have retinal hemorrhages, exudates, and the cotton wool spots, just like proliferative diabetic retinopathy. And the grade 4, that is the last stage or the advanced stage, we have optic disc edema, which is also known as malignant hypertension. So these are the 4 stages. Just remember one point about each stage, and only the classification part of hypertensive retinopathy is very important. So these are the 4 points, or these are the 4 grades of hypertensive retinopathy. Now, the next topic is the retinitis pigmentosa. So retinitis pigmentosa, it is a group of inherited retinal disorders. So it is an inherited disorder, okay, characterized by progressive degeneration of photoreceptors, which is photoreceptors are the rods and cone cells, okay, and retinal pigment epithelium. So the photoreceptors in the retinal pigment epithelium is getting degenerated. So that is known as retinitis pigmentosa, and it is a genetic, or you can say it is an inherited condition. So obviously the etiology would be the genetic mutations. So it can be inherited as autosomal dominant pattern or recessive, autosomal recessive, or X-linked. Okay, so this can be inherited as any one of the following type of pattern. There are types of retinitis pigmentosa. You have syndromic or non-syndromic type. In a syndromic type, the example is Usher syndrome. So Usher syndrome is a syndromic retinitis pigmentosa, and in the second class, you have non-syndromic pattern. Clinical features include night blindness because the photoreceptors is degenerated. So the rod cells, which is responsible for your night vision, is degenerated, or the amount of the rod cells is becoming continuously low. So that's why it is becoming difficult for you to see at night. And there can also be a peripheral visual field loss. And on the fundus examination, you can have bone spicule pigmentation. You can see over here, there's bone spicule pigmentation with waxy pallor of the optic disc. So there can be waxy pallor of the optic disc, and there can be bone spicule pigmentation very specific to the retinitis pigmentosa. So these are the fundus examination, and the symptoms include the night blindness or the peripheral vision loss. And there are 2 types of retinitis pigmentosa. One is syndromic and the other is non-syndromic. And we have also discussed about the definition, and this is a diagram of the fundus picture of the retinitis pigmentosa. Now, what is retinoblastoma? So retinoblastoma, it is a tumor. Okay, it is a tumor, and it has following stages like intraocular, extraocular, metastatic. So intraocular stage, that means the tumor or the retinoblastoma tumor is confined to the eye only. Extraocular means it has been spread beyond the eye. And the third stage is metastatic. That means it has spread to the other organs, okay, or to the other tissues. So we have 3 stages: intraocular, extraocular, or metastatic. So this was about the stages. Now, the histology of retinoblastoma reveals small round blue cells with flexner ventostine rosettes. Okay, so they are flexner ventostine rosettes, very important term to remember. So these are small round blue cells with flexner ventostino rosettes. In the clinical features, you will have leukocoria, which is also known as white pupillary reflex, or the strabismus. So leukocoria we'll discuss in the practical ophthalmology part, and the strabismus we have already discussed, which is also known as squint. In the treatment part, you can opt for enucleation, that is removal of the complete eyeball, leaving the optic nerve behind. Or you can go for chemotherapy or radiotherapy, which is common in all the tumor. Okay, so the retinoblastoma management includes just like any other tumor management, which is chemotherapy, radiotherapy, or if that doesn't work, then you can go for enucleation. So this was about the retinoblastoma. In the diagram on the right hand side, you can see this is the cancerous cell or the tumor which is present over the retina. So that's why it's known as retinoblastoma. Okay, we have discussed all stages in histology. Stages include 3 stages: intraocular, extraocular, metastatic. Histology, only one point to remember: flexner, ventostino, rosettes. Okay, it is very specific to the retinoblastoma. Now, what is enucleation? So it is a surgery. Okay, enucleation is a surgery. So surgical removal of the entire eyeball, leaving the orbital structures intact. So you're leaving the orbital structures intact, removing and you're removing the entire eyeball. Now, what are the indications for doing this surgery? If you are blind or you have a very painful eye, so you can go for enucleation, or you have any ocular malignancy like for example retinoblastoma. And what are the contraindications for enucleation? The contraindications include orbital infection like orbital cellulitis. Okay, so if you're having orbital cellulitis or orbital infection, then it is a contraindication for performing this surgery. And what is the procedure? So just like any other ocular surgery, first you have to give a peribulbar anesthesia, then sever the optic nerve and extraocular muscle, and remove the globe and place the orbital implant. Okay, so you have to place the orbital implant after removing the entire eyeball. So that is a part of the enucleation surgery. So the procedure is not very important for you. Just the definition, indications, and contraindications are important. So remember the indications and contraindications. So and the most importantly, the contraindications, that is orbital cellulitis, because it can be asked as a MCQ question because it is very important. So this was all about in our today's session. So we discussed about proliferative diabetic retinopathy and hypertensive retinopathy. We discussed about the retinitis pigmentosa, retinoblastoma, and we discussed about the retinal detachment, the risk factors, management of retinal detachment, and central retinal artery occlusion, central retinal vein occlusion. Okay, so retina, as such, it is a very big topic, but only a limited number of questions or the very important questions has been repeatedly asked in your previous year questions. So we have discussed only those questions that has been repeatedly asked in your exams, or has the chances, or is the most anticipated question that could come this year. So this was all about the retina. Thank you so much for your patience listening. We'll meet again in our next class. Thank you so much. Hello.
Yes, sir.
Thank you.
Thank you, sir.